Hello, everyone. How many of you never went to bed last night? Well, see, those people didn't go to bed, they just went to bed. That's why they're not here at the session. Well, thank you for coming. I'm Nancy Brown from Oak HLTH, which is an investment firm who has the distinct pleasure of investing in a lot of chronic care management companies. Sadly, not these companies, but this is a good beginning of a relationship. So this is going to be a great session. And just a few logistics. We have this thing called Slido. And so you can go on, I'm going to read this. It says, if you open your health app and you click on more, you can select a Q&A, session Q&A, and then select the track, which is track 2, session 1. And you can then submit questions to me, and at the end, we'll go through and we'll provide some of the questions, as many as we can get through to the panel. All right? Good. So we have prepared enough content to last, what is this? This is 3 hours? 3-hour session?
That's really going to be a problem.
You don't have anywhere to go, right? This won't be a problem. So I'm going to let each of the panelists introduce themselves, but I'm going to start engaging the audience in the beginning. So this is about chronic care. And I don't want any HIPAA violations, so you can choose to participate or not. But how many people in the audience are dealing with chronic care, either their own chronic condition management or someone in their family? Hands up. Mm-hmm. Okay. And how many people feel completely satisfied that it's going well?
No.
Excellent. This is going to be great. Take notes, everyone. So great. So. I'm going to start and actually jump in, and I'm going to let our panelists introduce themselves. I'm going to have them talk about not their whole bios. You can look them up. They're all on LinkedIn. All the details. They all went to a lot. I got the whole list here. Some of them went to Stanford, MIT, Michigan, University of Wisconsin. A couple people were at McKinsey. They seem to be okay now. They seem to have, no, it's just a McKinsey joke. So a lot of amazing backgrounds. But I'm going to have them talk about what their role is in chronic care management. So what are they hired to do? What is the job that their company is hired to do? And there's going to be a second part to that, but you can start with that. But I'm going to come back and talk about how we measure the impact that you're having. So we're going to start with Hank.
Great. Thanks, Nancy. Hi, everybody. I'm Hank, and I lead a business called Vively Health. And first of all, shout out to the health team because we changed the name of the business on Friday, so we threw them a major curveball. We're a subsidiary of DaVita and confused the health team quite a bit. And what we are hired to do is provide primary care in the home. So we are a medical group. We are a full risk medical group. So we have no fee for service. We are a virtual medical group, so we have no doctor's offices. Everything we do is house calls. And we're a high risk medical group. We only provide care for the highest risk, most chronically ill, 3 to 7% of members in the population.
That's it. That's all you do.
That's all we do. Pretty
amazing. David?
Good morning, everyone. David Van Sickle from Propeller. We're best known for connecting medicines to the network, inhaled medications in particular. But really what we do is actually try to close a gap that exists between what we should have achieved with chronic respiratory care, asthma, COPD, and what we've so far been able to accomplish as a society. This is a disease, or these are diseases for which we really don't need like magical inventions. We just need way better application of what we've already learned and built, both in knowledge and medications and treatments. So you can think about us as sort of a digital solution for asthma, COPD, for patients, physicians, pharma, and really providers and payers as well, working across all of healthcare there. It's great to be here.
Julie?
Hey everyone, I'm Julia. I'm the CEO and co-founder of Lark Health. Health plans and large employers hire us to manage their chronic patients or help folks at high risk of chronic disease prevent that. So we manage type 2 diabetes, hypertension, prediabetes, smoking cessation, and soon behavioral health. And we are a conversational AI platform, which means we provide 24/7 real-time text messaging for personalized counseling.
Oh, Mike.
Hi, everyone. Natalie Schneider. I'm the VP of Digital Health for Samsung Electronics America. And we're best known for phones and wearables. And what we do is empower individuals to take care of their health by capturing biometric data through a platform called Samsung Health. Samsung Health's got 80 million monthly active users. So through that, individuals are better equipped to manage their health day to day.
So in my line of work as an investor, I get a lot of chronic care management folks who come through the door, all different aspects. So this is really a great representation from folks that have devices, if I can say, that will contribute, full risk, specialized care, carve-outs, all of the above. And I almost every single time have to start with, can you just tell me what happens the day after you get a contract? Meaning, how exactly are your clients measuring success? What are they paying you to do? Again, you don't have to be specific. We're not going to go through contract review here, but just what are you being paid to do, and how do you measure that? What are your KPIs, if you will? In some cases, if it's relevant, you can talk about how many patients you impact, because in some cases you're a piece of a larger process, and so that's not a relevant question. In some cases, it is a relevant question. And we'll start at the end with Natalie, since we're going the opposite direction.
Well, in terms of just the day-to-day monitoring, that's free. But I'll talk specifically about a cardiac rehabilitation program we developed in collaboration with Kaiser Permanente. It's a home-based program. It uses a smartwatch and enables patients to complete an 8-week program at home. So in that case, we're paid per patient to provide that continuous monitoring and to provide that data with the patient's consent to the case manager. And to provide that clinical dashboard. And the whole purpose is to drive down readmission rates and to improve engagement rates.
And just since we've got you talking about that, how involved are you, or is your company? Do you just drop the devices off at Kaiser and they do the rest, or are you involved in the service side?
In this case, it's pretty end-to-end. So from the kitting and shipping, which means as you unbox the device, is the interface, the user experience especially designed for that particular application, right through to the clinical call center, the software, the hardware, so it's pretty end-to-end. What we don't do is actually any of the care delivery or the clinical support. So the case managers are all Kaiser case managers, the care protocol is a Kaiser care protocol, but we do sort of the technology infrastructure that enables that.
That's great. And just one additional question for you, because I'm actually may integrate some of the real-time questions here, which is, as they're getting data off the device, how are they accessing it, and how is it becoming actionable as quickly as possible?
So the user gets immediate real-time feedback on the watch, and they've got a companion app as well. And then there is a clinical dashboard. So as opposed to a more traditional program where you wait a whole week and a number of symptoms or concerning issues could go unaddressed or unnoticed for an entire week until that weekly case manager call, in this situation, that clinician can have real-time insights into whether that patient is being adherent or whether there is a need for a more sort of timely intervention.
Great, thank you. Julia?
Yeah, so LARC provides care to about 1.6 million people now. And I'll share an example of our AI diabetes nurse. So the health plan will say, please manage this 300,000 person population, and we'll go out there and recruit digitally, and right away someone downloads the service and they have a 24/7 care coach and nurse, and they can text with them anytime. So we deliver a device, a connected glucometer and a weight scale, and they'll be measuring their biometrics, but also, folks, I've had a chronic disease all my life, and it gets really frustrating at times. You feel really lonely, and a lot of times you don't have real data of like how you should manage this best. So essentially we try to provide that daily care. So if you're really stressed because you just got diagnosed, you can text at 10 p.m. at night with our LARC coach, and she'll do some AI, cognitive behavioral therapy with the patient. In the morning, if you want to eat a meal and you just tell LARC what you had, and the coach kind of coaches you with more disease-specific nutrition counseling. So we'll do all of the day-to-day management that kind of closes care gaps, as well as hopefully makes it a little bit easier for the patient to manage.
And just to add on to that, so you're an overlay to primary care, or an overlay to and are you distributed by the providers?
We are distributed by the health plans or the employer side, and our metric of success is outcomes and population health impact. So as an example, our AI type 2 diabetes nurse, 100% AI, was able to, within 6 months, show 1.1 point A1C reduction, which is equivalent to 21% reduction in diabetes-related deaths.
Okay, thank you. David.
That's what I love about digital health. Like the outcomes, the goalposts are so clear. And in Propeller's case, being able to monitor the medications that people are using when they're having symptoms, which really shouldn't be very often in well-managed chronic respiratory disease, it gives us this very immediate and clear feedback about how well we're doing. So it's so easy to set the performance indicators for the business around reduction in symptoms and unnecessary hospitalizations, acute care visits that are essentially treatment failures, and most of them are totally preventable or avoidable in chronic respiratory. So it's things like you can work through mechanisms like improving the patient-physician team and communication about whether they're on the right regimen and getting them there faster than they could have gotten there in an analog past. You're trying to increase adherence with daily anti-inflammatory medications that can have a real straightforward benefit. You're trying to teach people about the relationship between them and their environment and things that are around them at work or at school or in the community that are exacerbating symptoms. So for us, it's this immediate direct relationship kind of across the different mechanisms of action that makes digital health such a great business to be in. You can very quickly realize whether you're creating more value than you're capturing, and whether the population of people that you're looking after is doing better than they were before they found.
And same question for you. Are you going through direct to providers, through payers, in coordination? There was some good morning conversation about the pulmonologists and their role in your tool. What's the ecosystem you have to sort of get to move in the right direction to be successful?
Yeah, the more coordinated, the better in terms of the distribution and the downstream folks that we work with. Both the history of the company, we've been around for a long time, so I think we've had a chance to explore all of those different opportunities. There's been periods where we've tried different ways of getting to market, and now as part of ResMed, I think we have even kind of bigger aspirations to take on more of the relationship that people have with a disease from diagnosis all the way to end of life, and to do that in new ways with bigger organizations and bigger populations. So pretty excited about what's ahead for us.
That's great. You have a completely different situation.
Have a completely different situation.
Which I love. And again, this, just so people understand, the panel isn't about infomercials for all these. It's really about to compare and contrast. And so we've got a good contrast here.
Yeah. So I'll talk first about your question of what do we do on day one, and then I'll get to the results. So there's three primary things that happen on day one, and they generally happen concurrently. The first thing we do is we hire the team. So remember I said we are a medical group. So when we went into our first pilot market in Philadelphia, we hired 85 new DaVita teammates at that time in 6 months. So that was a combination of physicians, nurse practitioners, social workers, behavioral health specialists, pharmacists, palliative care specialists, care coordinators, et cetera. So we assemble the team in a new market. The second thing we do is all the analytics, because even though we start with the sickest of the sick, we still have to figure out who are the folks that are most likely to go to the hospital Monday, right? And we have to get into their home, we have to do a comprehensive health assessment, we have to manage their most acute conditions. And the third thing that we do, which is what you sort of alluded to with the other folks, is very importantly, while we are providing primary care in the home, we are not the PCP of record. And so it's very important to us to not disrupt local relationships in the community, to not have to say to the patients, in order to enjoy this amazing gift, you have to switch doctors. So the other really important thing we do is we get out there into the community and we have conversations with the local physicians, because it's our obligation to coordinate everything with them, to fax notes after every visit, to talk to them about changes in the care plan, et cetera.
So you said you're at risk. What are you at risk for if you're not the PCP, attributed PCP?
So I'm hopeful we're going to talk a lot more about this as a panel today. We are fully at risk for the total cost of care for the patient.
Interesting, but you're not the PCP.
But we are not the PCP.
Do you want to say anything more about that?
Yeah, I think I do. I would love to. Thank you.
They're like, oh no, she's off script. There we go.
Yeah. So one of the things that you have to always remind yourself in these situations, and I think David has a great story around COPD and chronic lung, is first of all, these are the sickest of the sick. So this is, we think about PCP attribution, but now boil it down to the top sort of 3 to 5% highest risk, most chronically ill. One of the things that we're big believers about is the idea that as risk is moving more towards the point of care, it's not actually ubiquitous, that there are natural owners of risk, right? And so the pulmonologist probably is the natural owner of risk for chronic lung and for COPD asthma, and so providing them tools and resources to do that. Our parent company, DaVita, right? The PCP is not the quarterback of the care for an end-stage renal disease patient. And so the nephrologist really is at the center, and in that case, the patient sits in the dialysis chair 4 hours a day, 3 days a week. We should be responsible for the total cost of care. And I think what we would say is there's a whole nother sort of carve out, to use your term, right? There's a whole nother category of patients, which is the highest risk, most chronically ill, who deserve their own care model, which is very different from the other 95%. And then the question is, how do you get the risk attributed for that small group, and how do you build a care model around it?
So I wasn't kidding when I said we need 4 hours, so let me try to net it out. So I think for anyone who's spent time in this space or has been in having a chronic condition or managing a chronic care patient, there's a lot of things that have to go right. A lot of things. And so the framework, the simple framework we created for this panel, which is it's an established framework, is the coordinating with primary care. So in most cases, even in yours, I did not know that, you still have other doctors. Sure. And even though the COPD, we have a lot of comorbidity, right? So there's other providers. There's technology. We're getting questions on the iPad for a lot about EMR integration. When you have, I call it carve-outs, but when you have this specialized care, they can become islands. There's no doubt in my mind that every single person on this panel has dealt with EMR integration issues. And you can tell me that everything's fine and it's great, but it's great when it's Kaiser. It's not great when it's 1,000 independent docs with EMRs under their desk or not on the cloud. And then there's reimbursement, which is a great question to go back to Natalie with in a minute. But just what the whole question of who's paying for what. And I think in some of the prep that was done by the team, if you begin to add up all the people who are being paid to take care of this attributed life, there's a lot. Yeah. And so each of those has to sort of go. It has to work out. And then there's this is a simple thing, patient adherence. So the other thing that has to happen, which we deal with a lot of our companies, is before adherence is actually finding the patient and engaging them. That is incredibly hard to actually get that patient in a timely fashion. And then the comorbid issue. So we obviously don't have time to go through all those, but I would love to, I mean, we will if you want later. We can all get together again and do that. But I really want to ask the panel, as you embarked on your mission, of all of these things, which has been the most difficult, which has gotten in the way the most, and surprising or not? And maybe you can talk a little bit about some of the innovation around trying to deal with it. And let me start down with Natalie.
So actually, in terms of what's helping and what's hindering, my two responses are going to be the same.
Okay.
That allowed. And I'm talking broadly, not Samsung specifically. It's reimbursement and technology. So with respect to reimbursement, we've come such a long way with the unbundling of CPT code at 99091, and then activating 3 additional CPT codes has really now created this path for reimbursement for remote patient monitoring. And so for the first time, you do have the ability for a physician, for example, to be reimbursed for setting up a patient's wearable for specific conditions or for monitoring that data. But there's still a lot of uncertainty around what gets reimbursed, how does it get reimbursed, and when it comes to things like digital therapeutics or even post-acute rehabilitation, I think there is a long way to go. So that is, we've come a long way, but still a lot of work needs to be done. And then the other one is on technology. We've moved from a world in which sensors were just too large to ever be embedded or to be worn, and now because of miniaturization, advances in battery life, sophistication of sensors, now they're actually quite useful and quite ubiquitous. So we've definitely raised the bar in terms of the quality of insights provided to both patients and physicians. But again, so much more to be done. So I'd say those are the two, reimbursement and technology.
That's great. Smooth sailing?
What's that?
Everything else has been smooth sailing.
Oh, everything else totally taken care of.
She only had one. She only had one. The other 4 are fine for her.
I set you up anyway. Julia.
Yeah, gosh, this is the 8 questions in 1 question.
Yes.
I'm going to go with reimbursement. It's been years for us. It was a years-long process. When we first started talking about conversational AI, it was not that cool yet. And people just immediately thought of Skynet from Terminator. So those are the things that we were compared to in a lot of meetings. And so it was really trying to find, here we were trying to promote this infinitely scalable version of population health management, because there's just not enough nurses in the world and doctors in the world to manage long-term chronic patients. And so we really looked for a way to make sure that it was accessible to the patient without them having to pay for it, but allow us to really put in all of the years of R&D to build this conversational AI. And so after we started, we launched in late 2015. Took us about 1 million patients to train our AI to get clinical outcomes equivalent to the live nurse, and specifically the CDC diabetes prevention program outcomes. And so, 2-ish years later, we became a healthcare provider, a DPP healthcare provider, and started doing medical claims billing as a program that often uses the 2,400 other healthcare providers use live individuals, coaches, diabetes educators to really manage this service. And so to bill under that CPT code, it took us about 2.5 years. And there's a lot of excitement on the way the new RPM codes are coming along, and so I'm really excited for that.
Great. And in fact, there's a question for both you and David around, do you see broader adoption for Medicare, especially with the new CPT codes for remote monitoring?
Yes.
I assume the answer would be yes.
Yeah, I'm going to talk a little bit about something else that's just been on my mind, which is around the regimens for chronic respiratory disease, and it feels like there's been sort of a failure of the imagination that if you have a daily regimen and the majority of people aren't taking it, at some point you have to wonder whether you just need a better regimen, and whether the problem isn't with how creative or how we could innovate at the frontier of using digital in combination with treatments in new ways, in novel ways that are more appropriate to patients kind of at the time and place of risk and impairment and evolving situations, and less about kind of these monolithic treatment regimens of the past. And I feel like we're just getting to that point in respiratory, where we're recognizing that there's lots of more dynamic ways to treat an individual and a population, and that the border between individual clinical health and public health is kind of an artificial, stupid one that we should traverse all the time. So I think there's some legacy tension there between the way we developed guidelines and treatment protocols in the past across a population and the way that we could potentially be heading with sort of digital drug device combinations in the future. Does that make sense?
No, it's a great, and hopefully everyone got that. You made perfect sense. It's early, so it's an important topic, which is, and it's been a focus of my work forever, which is that there are ways in which to approach getting to cost and quality outcomes that are new and often have been developed by what people might refer to as contrarian providers, who have experimented. I don't know if that's the right word. Who have gotten to outcomes in a much more efficient and effective way, and a lot of actually venture-backed companies are based on those very those individuals, those clinicians, trying to figure out how to lift and shift the model that has been created. But the other thing that at least I see that was very different than my days, I was going to say nonprofit. I don't want to paint nonprofit completely, but we, as each of your companies are backed or you have investors, there is a complete focus on the achievement of the quality goal that you've signed up for, but trying to do it as efficiently, which means like A/B testing or testing all of those different regimen, we'll call it a regimen, or the process you're applying, and making sure that everything you're doing is actually useful. And I started out evaluating traditional healthcare in that way, and there's a lot of artifact and legacy. So it's a very interesting point.
So I think all 5 things that you said are hard, Nancy, at least for us, for me. The one that I'll pick out is patient engagement. So not just up here, we have a room full of entrepreneurs. When you start a business, you have this point of view of things that you think will be really hard and things that you think will be really easy. And of course, invariably, it's exactly the opposite. And so, if I thought in the beginning about our, pitch, so to speak, to the patient, and I said, what we want to do is we want to come into your home for as long as you want and provide you as much health care as you want. It'll be comprehensive and coordinated anytime that's most convenient for you, and you don't have to pay for it at all. And then you would come back and say that more than half of the people would be like, no thanks, I'm good, right? I wouldn't, in a million
Crazy.
years, I never would have thought that would be hard. And the contrast that we use with our team is Airbnb, right? So hotels are not a problem at this conference, but the conference that we won't name in San Francisco, I can never get a hotel room, so we get an Airbnb, and so I sleep in someone else's bed, I shower in their shower, And somehow both sides have convinced themselves that's totally normal, right? But all I want to do is just go in and provide free healthcare for as much as they want, and we can't do it. And so our answer to that is, I'm convinced that I don't know the answer, they don't know the answer, and none of you know the answer either. So we're going outside of healthcare, and we're just trying to bring in executives from consumer and digital, and getting help from the fields of behavioral economics, because this one has definitely proved harder than we expected.
We have not met before today, although I feel like we might be twins of different mothers here, because I give this speech all the time, which is, I would love for someone to show up on my door. We have many companies like this, like Quartet. They're like, you need more mental health services. Could we give them to you? And we can't. Yes. So this is a great segue into the discussion of patient engagement, which again isn't. And again, until I began to invest in these companies and realize that you start with there's a whole world of which patients should you be focused on, which is not always And we
messed that up.
And so there's the analytics associated with trying to find them as early as possible. So I'm just going to sort of lay out the framework. Then there's okay, we know who the patients of interest are. Some of them raise their hands, but some of them we have to find. And then we have to get them, and sometimes through primary care, direct calls, using consumerism. We're now got choices to go through Walmart, go through CVS, go through some retail places, anywhere you can find that patient. And this is an amazing thing to me, because almost, I think everyone here has contracts with payers. Payers spend a lot of time picking all of you, and then there's almost like, you know what I'm about to say, and I love all of the payers, all of you in the room, but it's hard. It's very, very hard to. There's almost nothing they can do to help, or that they do to help to get to their patients. Yeah. And so we're all going and we're applying some direct to consumer. There's all sorts of, some people are gamifying it, there's all sorts of things. So, and then once you get them, then we get on to the thing we normally talk about, which is how do you get them to consistently, you're all measured by how long did they use it? You know, did they stay on? Did they get to the milestones? Many times you don't get paid for the digital pieces until they hit certain durations and outcomes. So I think we're going to do rapid fire here, because we're running short on time. I have one more topic after this and a few questions. But you just gave us some input to that. But if you have something more.
Yeah. So two things that you mentioned, Nancy, that I think are super interesting. So the first is identifying the right patients. So we definitely did this wrong in the early days, because we said, show me everybody who is sick. Show me everybody who has diabetes, who has COPD, who has CHF. And what we found is, part of our engagement problem when we would call them up and they would say, no, I'm good, is they were actually good, right? There is, in fact, a regression issue in this business, which I think is not only a patient problem of we're bothering the wrong people, and we don't only have false positives, but we have false negatives. But then there's also problems with the economics, right? Because we shouldn't be getting paid for patients who are becoming less costly on their own. So I think that's a really big issue. And so the way we've addressed that is we've just completely redone the predictive analytics to select patients based on rising risk, not only on who they are today. I think the second thing is just the very basics of your points of the payers not helping us as much with the data itself. So we will find that 30% of the patients in our file right off the bat, it's just bad contact information. Oh. And what I always say to the payer is, forget about us and our ability to deliver on the contract and do what we want. Aren't you worried that you can't find 30% of your sickest patients? Yeah. So I think that's a bigger issue, where we're just bringing in other data sets and other sources to find them.
Great.
Yeah, quickly, I think it's one of the more interesting tensions in digital health, actually. What I would think of as kind of like non-overlapping population segments of interest. So payers being focused in particular on the folks you just mentioned, the most sick, often retrospectively. Pharma having a very different and kind of wider swath of the distribution. Digital really having application across the whole distribution, and there not being a whole lot of consolidated view about the way in which they could all be integrated under a single solution. So there's like some really interesting heterogeneity in where you want to focus, and I think you have to reckon with that as a company, as well as just in your commercial offering. So.
Yeah, there's so many things that you need to optimize in this funnel, right? And one of the things that I think is actually almost a little bit more perverse. Yes, there's a lot of technology issues, right? there's only 1/3 of emails available for this 500,000 person population. But also, I think that there are some issues where there's just a OpEx constraint. You only have X amount of nurses, so you have to focus on those top high acuity patients. Or, there's extreme focus on individual level outcomes rather than population health impacts. So it's almost perverse incentives to find and treat the highest acuity patients and leave the rest, mod acuity and low acuity to fend for themselves. And so I think that it's a hard problem all around. For us, we think that if you can treat the folks that want to be treated, even if they're not as far along in the sickness spectrum, that if there are ways to treat them in a cheaper way, and so for us it's really about using conversational AI to focus on first line of defense work, where the folks that need some help but not the 24-hour live clinical resource help, that they can get the help.
So I think sometimes you get lucky right out the gate. You mentioned a number of things have to align, and with our cardiac rehab program, we had graduation rates of 87%, and that's compared to the average of about 50%. So great engagement. But more often than not, we know people act irrationally. We know they frequently contradict preferences that they previously stated. They don't act in their own best interests. Classic behavioral economics. But increasingly, I think what's encouraging is to see policymakers, health plans, others not only account for this in terms of how they create those systems of engagement, but actually capitalize on it. And capitalize on the fact that we prefer immediate gratification, guilty as charged, and design incentives whereby you're focused on sort of current, not future events, and also using proven mechanisms like the literature again and again reinforces financial incentives, highly effective at certain health behaviors. Cancer screening, pre and postnatal, smoking cessation, not so much weight loss. So I loved what everyone said about behavioral economics, and I think even with the best insights, most accurate, most timely insights, logic doesn't always prevail, and it does. We really do need to capitalize more on behavioral economics.
We have less than 3 minutes left, and I have so many questions, but it's not about me, I'm told. Okay, so let me go to the questions in the audience and ask a couple. There's one specific question for Hank. I have 2 questions for you. Although I don't think this is a question for you, but you can answer on behalf of your parent organization.
Okay.
It says, do you think that your company will eventually make the dialysis facility a patient-centered medical home?
I think it already is.
Say
I think
more.
it already is. So let's go back to this concept of the natural owner of risk. Unlike so much of healthcare, the dialysis patient sits in our chairs 4 hours a day, 3 days a week. The PCP is not the quarterback of the care, the nephrologist is. We have full total cost of care risk for over 10,000 of our patients. So again, full cap, up, down, in every way. We have no choice but to think about kidney care as integrated kidney care, and it is the way of the future. I think where it gets even more exciting for us is when the payers follow along where the government is start going and saying, hey, let's think about kidney care, not dialysis care, right? And say, let's move upstream towards the later stage CKD patients and create one risk pool where we say now the providers have the incentive to delay the onset of dialysis, to manage the total patient, to find the right modality, whether that's home dialysis, whatever it might be. So we love the idea of moving more towards the medical home.
Great. Okay, last question is for Julia. And the question is, you mentioned when working with a health system diabetes population, you recruit digitally. And so they just wanted to hear just a 1 minute, 52 seconds on that. 50, no pressure.
So we come from a very consumer tech background. And so my whole growth team is actually from consumer tech, where it's all about digital acquisition and CAC, customer cost of acquisition. And so we will meet the patient where they are, and that's Facebook. Take a 1 minute quiz with our LARC coach and see if you're qualified. If you are, you get a $600 program for no cost. We chat with them at the pharmacist place. So at point of care, the pharmacy, the patient comes in to get their statins, and then the pharmacist says, hey, you've got a covered benefit here. What's your cell phone? They type it in, and within 1 minute, the patient is chatting with their AI nurse on the spot.
Great. Thank you so much. Thank you to the whole panel. It's been terrific.
Thanks, Nancy.
Thank you.
Thank you.